And I compliment Cesar for some interesting historical facts. I would propose that Dr. Fauci is very upset because Dr. Halstead did not have a mask on. He didn't have that on even in the OR, but then times have changed.
Remember,
We have different rules in Miami.
That's true. In this crazy world and the change that's going on, I always like to look for things to keep me optimistic. And at this point, I am actually really excited. On Tuesday, my wife and I were approved for a loan to purchase a full tank of gas. And if that isn't exciting enough, we actually, in the Annapolis area where I live, we have a location that is actually selling gas for $2. Now, on a more serious note, is I would really like to compliment Dr. Gulick. Cesar and I met, I don't know, 10 or 15 years ago in Turkey and gave back-to-back talks on dosimetry. And he then came to Miami and started this symposium in Miami locally. And now it's become not just national, but international. And looking at the participants, there was virtually 200 participants for his meeting right now. So it's quite an accomplishment. And this is a distinct change from the number of individuals in the audience when I presented in Turkey. Now, in all seriousness, really my reception in Turkey was much better than that. So my congratulations to Cesar for a great program, the number 5, and we will look forward to number 6. So let's get down to business. So Cesar asked me to do a talk on the science of radioiodine, and this word science has really gotten a lot of play with COVID and Fauci, and everybody's got the science to back up their opinion. And I try to avoid that, but we're all guilty to that in a little bit. But I want to look at active surveillance versus I-131 therapy, which is really watchful waiting and why wait. Now, yesterday, this was previously addressed regarding remnant ablation, and this is really a presentation on low-risk thyroid cancer and adjuvant treatment. These are my disclosures. I also disclose about my slidology, that I'm breaking that first rule. And as I mentioned yesterday, I'm including more text than before. And that is because I do distribute my slide set when you email me. Here's my email address, and I'm happy to send it out. So the objectives for this session is really the 2 major approaches to low-risk patients, which you really already know about, and is active surveillance for watchful waiting. And we're not talking about remnant ablation, but we're talking about I-131, and in this case, adjuvant treatment as defined by the 2009, 2015, and the Martinique Working Group, adjuvant treatment, and why wait for administering I-131, and discuss the limitations, reservations, and lamentations of articles supporting less is more or more is less. And then I'm going to resolve the controversy. And that's a pretty bold statement, but that's going to be my objective, and describe future initiatives. Now, one of the future initiatives that I was going to discuss has just been published, and we'll also address that. And Cesar, I believe, yesterday, yes, he did, yesterday, discussed a little bit about this, and I'll talk about it more. My favorite quote, or one of my favorite, is, "It ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so." And a couple of philosophical comments. We have to remind ourselves we really have more areas in common than we have differences. and we all should celebrate our differences, and actually our differences should be the workbench of progress. And I think with the premier speakers on this program, we are all working at the workbench to try to figure out what's best for the patient. Now, the two major management approaches for low-risk disease, again, remnant ablation, having already been discussed yesterday, is active surveillance, watchful waiting, or less is more in the lingo or jargon of many, or I-131 adjuvant treatment, which we're going to talk about, and that's why wait or more is less in the jargon or lingo. And you already know that. I'm actually not going to go through all the articles that support less is more, or go through articles that's more or less. This is a little bit different presentation. I'm going to discuss the pros and cons, not going to discuss the pros and cons of each article. I want to move to my second objective, which is really to discuss the limitations, reservations, lamentations of articles supporting either less is more or less. And there are at least 9 of these items that I want to address today. So number one, there's no conclusive prospective study. And again, I will discuss the study that just came out from Gusto Rossi from Lebelou. And theoretically, there's no randomized, good control prospective study that's been published with long enough follow-up comparing any post-op therapeutic strategy with or without I-131 adjuvant treatment for patients with the many categories, and that's an important operative word of many, of low-risk differentiated thyroid cancer. Number two, an absence of evidence is not an evidence of absence. So there's been no inferiority studies, or non-inferiority studies are required, and the power to be a non-inferiority study and to reach statistical significance requires lots and lots of patients. Now, as I'll mention later, Lebelou's publication is a non-inferiority study, and we'll address that. And the power means high numbers of observation. But until date, till this day, other than Lebelou's study, there's been no non-inferiority study to really assess the effectiveness of the I-131 adjuvant treatment or active surveillance in low-risk disease. Not talking about remnant ablation, different discussion, and Dr. Gulick has already been addressing that. The number 3 lamentation is not enough follow-up. And this is very concerning. So if one looks at this table, which I thank Dr. Marcus Luster from Germany, who tabulated this from Anna Saka's, now editor-in-chief for the Thyroid Journal, from her article in 2004, if one looks at I-131 effectiveness in cancer, the studies that were statistically significant all had follow-up of 17 years, 11 years, 11 years, and 12 years. Long-term follow-up is needed. One of the problems with our present studies is the long-term follow-ups are very short. For effective cancer mortality regarding I-131, the Ohio State has statistical significance, but their follow-up period was 17 years. So not enough follow-up. And this is a real problem for all of us. Promulgation of incorrect conclusions. So this is a study from Maria Castagna. Maria is an excellent physician and researcher, and I've distilled her article from Journal of Endo, and this data is all present in our article, and was looking at recurrent disease, biochemical disease, metastasis, persistent disease, or death at 30 millicuries versus 100 millicuries. And all patients 40, T3NOX 26, 28, none of this is statistically significant. And I think her conclusion was adequate, which is our study provides the first evidence that in patients at intermediate risk, high radioiodine activities have no major advantage over low activities. Now, subsequently, and I haven't reviewed this in the last several years, but there's been 13 articles that have come out, and they have quoted this to say that 30 millicuries is equally as effective as 100 millicuries. And I would submit to you that one could conclude that these are equally ineffective as 100 millicuries. So that 30 millicuries and 100 millicuries may not be enough and one needs more. And this is actually a limitation of low-risk disease regarding how much radioiodine we're giving. So the promulgation is of a potentially incorrect conclusion that 30 millicuries is as effective as 100 millicuries. So when we look at active surveillance versus 30 millicuries, that's most likely ineffective. And in fact, one may need to give more. The question is, in what low risk, if any, but in what low risk patients should higher activities for adjuvant treatment be given? Now, moving patients that were staged as intermediate risk to low risk disease is another concern. This is the ATA guidelines in 2009, and this group of patients essentially has been moved to this. And now we're dealing with a group of patients of what's really low risk disease. 1%, less than 1%, 1%, 5%, 10%, or distant Mets. And this is an issue in that low risk disease. So we typically estimate that if it's less than 5%, that's really low risk disease and active surveillance is okay. But by whose standard? So here's some of the low risk disease. This is a PN1 without external node extension. 3 lymph nodes are involved, but 3 or less involved, less than 0.2 centimeters, 2%. Multifocal, 4 to 6%. Intrathyroidal, 5%. These are all listed under low. All lymph nodes less than 2%, PN1 less than, as approximately 5%, et cetera, et cetera. So the question becomes, what really is the standard? Less than 1%? I can buy that. 1%, 5%, 1 in 20, 10% have difficulty with that. Is it your standard, my standard, or what's the consensus on that? And I'll talk about consensus in a minute. Or the patient standard. Patients have different viewpoints. Some may be minimalists, some may be maximalists and want more. Interestingly enough, the European Consensus Conference and the Latin American Thyroid classify patients as being either very low risk or low risk. And these are 2 different groups. These would be all classified by ATA as low risk. I will assume that in the new ATA guidelines that these probably will be split out. However, a patient perceives these percentages may be very, very different. Number 7, you can always trust later. Beware of this, or always treat later. Beware of this premise. You can always treat later, but not necessarily as well. You can always treat better if you cure now, rather than if you treat metastasis later. Of course, the opposite of that is how many people do you have to treat now in order to save metastasis in patients later. Consensus. This is very interesting. In the absence of good evidence, consensus is one surrogate that we use. But be wary of consensus. In the 1920s, the consensus was that the roaring 20s would roar on. And it was good times, and the good times were going to last. Only right after 1929, this is what the good times were. So consensus is not necessarily a good criteria. In the late 1500s and early 1600s, the universal consensus was that the sun rotated around the earth. And good old Galileo came along, and he was sentenced to be executed. Now, a important aspect of Galileo is that he thought he was crazy and that this was just his opinion, and that opinion meant nothing at all. And in fact, Galileo said the following: in the sciences, the authority of thousands of individuals is not worth as much as one tiny spark of reason in an individual man. So we need to be careful about consensus. This is not just in the 1600s or the 1920s. It's been this throughout history. And just look at our last century regarding present day politics and even COVID-19. Be careful about consensus. But you say this doesn't happen within the science of differentiated thyroid carcinoma. Remember the Castagna article and the 13 articles that it referenced. And it referenced that it was a consensus and that there was no difference between 30 and 100 millicuries. The question being is there a difference between active surveillance and I-131 therapy? A simple falsehood is better than a complex truth. In our practice, we just see it's very easy. They're low-risk disease, then they don't need I-131 therapy. This cliche creeps into a lot of our practices. Now, not necessarily at some of the academic institutions, but sometimes in more of the more rural institutions. And I'm confident that no one does this consciously. However, the forces are there in those facilities to be more efficient, to be more productive. And even in our large 1,000-bed hospital, there is a movement of increased efficiency and RVUs. They're tracking RVUs, and this may directly or indirectly affect our practices. And so this can subtly or subconsciously affect our favoring recommendations that are easy, such as active surveillance. Again, a cautionary. I'm not saying one should do active surveillance. I'm not saying one should do I-131 therapy. A simple false is better than a complex truth. Less time spent on patient education discourages patient questions, no informed consent, and you can think of other mechanisms that are beneficial to we practicing physicians. We need to be aware of that. It can result in increased productivity with increased RVUs, less liability, and rightly and wrongly, the patient senses that his or her problem is not concerning and less apparent confusion within the patient. So what I've tried to do in this limited time is that we need to be cautious, and there is more and more information coming out, and the limitations and reservations and lamentations are no conclusive prospective study performed. An absence of evidence is not evidence of an absence. Follow-up is just not long enough. The argument you can always treat later, need to be cautious about that. Maybe you can't. You might be able to treat, but not as well. Promulgation of incorrect conclusion, moving patients that were staged as intermediate risk to one large low risk category. And what really is low risk? Consensus and Galileo. Consensus is just that, consensus. It is not necessarily truth. Be cautious of the forces that encourages simple falsehood that is better than a complex truth. Resolving the controversy of the management of low-risk disease. If you guess that my position favors more is less and thus I-131 activity, you are absolutely wrong. I'm often accused of putting I-131 in everybody's drinking water in the division every day. My position is personalized medicine, and I think we're moving towards that. And in listening to the discussions during this nice symposium, this is really where we're moving. And personalized medicine is staging, adequate staging. I'm a strong believer in pre-therapy diagnostic scans, quality pre-therapy diagnostic scans. And this is actually data from 6 articles that show that when scans are done well, they can alter management. This is 6 more studies, actually 7 more studies with further data showing alteration of management from 22% all the way up. I think 88% is a little high, but it alters management. appropriate preparation of the patient for pre-therapy diagnostic scan, adequate elevation of TSH, low iodine diet, confirming the iodine is low in the urine, appropriate performance of the pre-therapy diagnostic scan. I've spoken at many other presentations, and the key is really that not all radioiodine scans are created equal. Here's one whole body scan, a large area of activity in the thyroid bed. Surgeon left a lot of activity behind. We have a star artifact. Maybe we need a different surgeon. The rest of the scan is completely negative, but when one does a pinhole collimator of that image, there is, I've already counted them, 13 foci in the thyroid bed on that pinhole. And clearly, this is highly, highly unlikely to be residual normal thyroid tissue left behind for the surgeon. This is metastatic lymph node metastasis from differentiated thyroid cancer. And again, this data about radioiodine scans and simple techniques, nothing earth-shaking, but simple techniques that, at least in my opinion, are rarely performed in many local institutions, will alter the interpretation of the scan and the stage of the patient. Genomic and molecular testing with Nikiforov and others, comorbidities, this is what really determines, and I think we're moving in this direction with talks such as Mike Tuttle's and Nikiforov's, benefits versus risks of the I-131, patient desires, is the patient a minimalist or a maximalist? At the Martinique meeting in 2000, I forget what it was, 18, Mike Tuttle introduced me to this book by Gutman and Hartspan. It's an outstanding book. It's your medical mind, and it's not just a good read for a physician, it's a good read as a patient on how we look at things and want to be a minimalist or a maximalist. And that may affect whether one is doing active surveillance or an adjuvant I-131 therapy. Is the patient comfortable with treating later if necessary? Patient compliance. For 10 to 20 years, if recurrences are going to occur that far back, the ability to follow that patient, all these factors go into it. The work environment is also very important. Facility forces are at work on physician practices. I've already mentioned this. It's not necessarily patients first. I have to say sometimes it's RVUs first, and that's becoming more and more of a problem. And you should not consider, for example, referring a patient to a competing institution. So insurance coverage and then other issues of various country healthcare systems. So for me, it's not active surveillance. It is not I-131. It's personalized medicine. And as I think the other speakers at this program have really shown, things are becoming much more complicated. But as they become more complicated, we're trying to, and we're improving in sorting out who really has a reduced prognosis. So to describe future initiatives, there's the F.A.C.P out of France and the ION from Great Britain. And this was a slide that I've used before from the F.A.C.P from Gustave Roussy, from Dr. Schlumberger. And what's interesting is this just got published in the New England Journal of Medicine. And I think it's worth a few minutes of my final few minutes of time to review this. And here's the article by Sophia Lebelou. She's absolutely a delightful young lady. And I think she overall did a good job. It's a prospective study. It's open label, randomized phase 3, multi-institutional, non-inferiority, which it needs to be. And it's randomized to post-op radioiodine ablation versus follow-up without radioiodine ablation. And it was published in one of the premier journals of the New England Journal of Medicine. However, the conclusion is verbatim. In patients, and I'm going to read it slowly, with low-risk thyroid cancer, undergoing a thyroidectomy, a follow-up strategy that did not involve the use of radioiodine was non-inferior to ablation strategy with radioiodine regarding occurrence of functional, structural, and biological events at 3 years. Now, I have 3 reservations involving this. I-131 activity administered, low-risk classifications, and duration of follow-up. The conclusion verbatim, low-risk thyroid cancer, use of radioiodine, 3 years. Let's take a look at this, 30 millicuries. Is 30 millicuries enough? I-131 activity is not, 30 millicuries is not sufficient for the conclusion, and this is the conclusion, that active surveillance without radioiodine is non-inferior to the use of radioiodine. It's non-inferior in this study to the use of 30 millicuries of radioiodine. How about 100 millicuries or 150 millicuries in select patients? 30 millicuries is not enough to make such a broad, misleading statement about all activities of radioiodine. Now, in the original study, PTNXM has been removed in this publication, which is unfortunate because that would have been very interesting for me. However, it's PTA-NXMO, and this is a risk of recurrence from the ATA guideline in 2009. And that group has essentially been moved to the ATA 2015. That's a very large group for low risk. Low risk disease, in the conclusion in their abstract, may mislead individuals that anyone classified as low risk should do as well with or without radioiodine. Low risk disease, based upon the 2015 ATA guidelines, and I'm sure that'll be modified with Matt Ringel and Julie Sosa's 2023 guidelines, will be distinctly different and cannot be extrapolated. SOPHIA only studied PT1A, 2B, NONX, MOMX. This does not encompass all of the so-called low-risk group. The original plan for the study was 5 years, and they've done actually 3 years. Duration is not long enough. Durante and Dong were quoted for this by SOPHIA in JCEM. Follow-up was 10.4 years, relapses were 8 or fewer years, and they evaluated 1,020 patients. Sounds good. However, 908 had radioiodine therapy. If you want to know a natural history, you don't give them radioiodine therapy and only follow them for 3 years. Dong published in Thyroid 2019, 460 patients, and we're coming to the end of my time slot. And the mean time to initial cancer recurrence was 9 years, and specifically for local recurrence, 10 years, regional recurrence, 8 years, etc. Now, this is a study, again, that I've shown earlier from Marcus Luster, tabulating Sauka's data, again, emphasizing 3 years is not long enough, just not long enough. So the 3 major problems that I may have with is that there's three major problems misleading practitioners and patients and third-party payers, and third-party payers will jump on this. Extrapolating a non-response to 30 millicuries to higher activities for adjuvant treatment. Extrapolating their data from very select low-risk patients to all patients within the low-risk category. And extrapolating data of only 3 years for follow-up is insufficient. One needs longer follow-up, such as 10 to 15 years. In my opinion, if you're going to treat with I-131 for suspected but unproven remaining cancer, then perform I-131 treatment with administered activities of 100 to 150. 30 millicuries is for remnant ablation to destroy normal residual tissue with no objective of reducing recurrence. The ION study, because I'm at the time limit, I will skip. In summary, it ain't what you don't know that gets you into trouble. It's what you think you know, such as for this study without knowing the limitations, that gets you into trouble. We have more things in common than differences. Let's celebrate our differences. Differences are the workbench of progress. And in the sciences, the authority of 1,000 opinions is not necessarily worth as much as one tiny spark of reason in an individual. Again, those were the conclusions of my points. And my opinion is less is more, less interpreting guidelines as sacrosanct, and more personalized medicine. I'd like to thank my team, and that's my email address for
Oh, this is
slides, and this is my research team. Thank you.